Hi, you're listening to What's the Schemata, a schema therapy podcast for therapists, with ISST accredited schema therapy supervisors and trainers Chris Hayes and Rob Brockman. For more information on schema therapy, visit our website, schematherapytraining.com.
Hi everybody, welcome to What's the Schemata. This is a specialist podcast for those that are interested in schema therapy, and my name's Chris Hayes, and I am here with the mighty Rob Brockman. Rob, how are you?
Mighty. Yeah, I'm good, Chris. How you doing, mate?
Yeah, good. What episode are we at now?
We are on episode 21. We're racking up these things.
We made it. We made it to 20.
Yeah. Yeah.
We don't have
it's a
any
real
more.
thing. It's a real thing now.
It's a thing, yeah. It's we're steady. We're going steady.
Yeah.
I mean, we're going a little bit freestyle today. Often we have people presenting and we're interviewing people, but we thought that we could have a bit of a chat, and we thought that the idea around discussion around limited reparenting would be useful for a lot of people that are learning the model, training in the model. We often get a lot of questions and a lot of probably misunderstandings around limited reparenting, which is a big part of schema therapy. Yeah, the what ifs. Yeah, the what ifs, and we thought we'd just sort of dedicate it today, on that, that compartment of schema therapy. It's a big bit. I mean, I don't know. Do you find there's a lot of people asking questions and there's maybe miscommunication or misunderstandings around limited reparenting too? Is that your view?
Yeah, I think it's one of both the most exciting part of the model, but also the most anxiety-provoking maybe part of the model. Yeah. There's a lot of things about limited reparenting, isn't there? There's sort of putting ourselves in there more.
It's more activating for therapists, yeah. I guess. It can be more triggering.
Can be.
Out of their comfort zone. Yeah.
There are those therapists that look and go, "Oh yes, this is what I've been looking for. Like I have a model to do all the things that I already do." But then there are others that are like, "Oh, this feels a bit, sort of getting in there and like putting myself in there and." So there is that too.
Yeah. Because I guess we should probably just back it up a bit for those that are new to the model or learning about the model. One bit of schema therapy is limited reparenting. Okay, limited reparenting really is it's a therapy relationship. We want to go beyond the standard level of care, and we'd see. Limited reparenting is we're trying to provide in a limited context what needs were not sort of met in childhood. There's a particular style that we have. If you're listening to a tape or something, I don't know. I can tell. I don't know about you, but I can automatically tell if someone's needs some work around limited reparenting versus not. Some people are just very natural to it. So I guess, I often see, like other therapists, particularly maybe that don't come from obviously not from a schema background, but maybe more psychodynamic or other approaches where it's more that the therapy relationships just develops over time and they just want to get a safe environment.
And different models have an idea of the therapist as more of a blank slate thing as well.
Yeah.
Where they wouldn't be putting themselves in there, but more just kind of reflecting.
Yeah, so we kind of talk about and think a lot about how we can get the therapy relationship really going rather than just needing more time. And it's a part of the structure and the architecture, really, a kind of schemas.
So limited reparenting, right? This is one of the 4 intervention points, the big intervention points in schema, right?
Yep.
So we've got limited reparenting. The other 2 are more or less cognitive behavioral therapy. So we've got cognitive techniques, we've got behavioral techniques.
Yep.
But Jeff Young, in designing the model, he added a couple of big things. So one of those things was limited reparenting.
Yep.
And the other thing was the experiential techniques.
Yep.
Okay.
Yep.
So those coming from a CBT background, there's a lot of familiar things in schema, right? We've got cognitive and behavioral techniques. We've got this cognitive information processing model, okay, which happens to be a mode model now in schema, which is a bit different, but it's still familiar maybe to many therapists, that kind of formulation. But limited reparenting is one of those really distinctive features, of schema. Distinctive feature, right, in the sense that we as therapists, we're going to set up a therapy context where we are going to put ourselves more in there, right, into the therapy relationship and try to directly meet some of the core needs that were unmet, for the person when they were growing up.
So they can be kind of intimate, kind of. I mean, when you're talking about directly meeting the needs, I guess, when I'm working with my supervisees, it's sort of things like, rather than being Socratic and kind of like, so is there any evidence that would suggest that, you can't do this presentation? It's more being direct, going, you could do this, Rob.
Yeah.
It's funny.
Well, maybe not as much like that, but.
But you know what? It's interesting. I ages ago, when I was doing my accreditation, I had a colleague of mine. I don't know if I told you this, but he's an American guy, and he's got, he's quite a lovely bloke, and he's quite quirky. And I was talking to him. I was early in my career, and I've got a bit of a failure schema bubbling in the background.
Yeah.
And I still remember it because it obviously hit a nerve and really, it was quite corrective. And I was just talking to him in a tea break or having a chat with him and talking about my career or talking about doing something out of my comfort zone. Maybe it's a presentation. And he was like, "Hey, Chris, you got to believe in yourself, man. You can do this. You got this, man." I still remember him. He was sort of, been directly meeting that need, and it's still, it was quite telling at the time, I think,
I had a guy like that too. He was a particular supervisor I was seeing for a while who was an ACT supervisor.
Yeah, right.
And he had this way of, and I hold that in mind now, he had this way of looking at me, and if I had some self-doubt about something, and I said, look, is this, could I do this or something like that? And he would look and he would just say, I know you can, Rob. He goes like, I know you can.
Yeah. That's it.
And that was like, oh, And like if someone doesn't believe something, they wouldn't say that.
Yeah, absolutely. So we're bringing a lot, I guess that's the directly meeting the need element to schema therapy, is like being direct as opposed to,
we joke around saying, you could do this. But really it's that pulling them in saying, mate, you've got this.
Yeah, you got this.
This is okay. Maybe it wouldn't work out, but this is not beyond what you can do, right?
Yeah, and it being linked to the need. So for me, I don't know if it's the same schema for you or not, but the need of a failure schema, I need someone to sort of encourage me and
we just keep talking about our failure schema.
Yeah. Or it might be somewhat, if it's emotional deprivation, I guess what we're trying to look at is being direct in saying, hey, I care about you. I've got you in mind. I know it's going to be hard on the weekend, but I want you to know that you're not invisible to me, and you've got you in mind over the weekend. That's quite intense for some therapists.
Now, something that I actually picked up relatively recently, like at our Connect conference, like 2 weeks ago.
Yeah, right.
Remco did this thing where he was talking about limited reparenting and experiential techniques, but he just had this really basic model of, like a 3-part model of activating the schemas or the vulnerable child. Mm-hmm. So schema activation, corrective experience, and then reflection and consolidation.
Yep.
Okay. So, and he brings this into his limited reparenting. It's really cool. I've never thought about it that way.
Yeah, right.
And it's obvious that that's probably how we should think about it. But so, and what it means is when you give this kind of, direct message to the client, you have to make sure that they're activated with their schemas. If they are, let's say they're in a coping state, let's say they're sitting there in a attached protector, and you're like, mate, you've got this. And they'll just be like, yeah, I know. Okay.
Yeah, whatever.
You know what I mean? So it won't land. So the model is, you have to remember, like when we are saying these things, and I think schema therapists get very good at, I don't think we always think this way about, activation, corrective experience, reflection. But we get very good at knowing, the client's activated. They need something from us right now. They need to hear something. But that's worth keeping in mind, I think. So.
Yeah, because I think, sometimes you might see speaking in that way, being kind of nurturing and very direct in that way can be sort of activating itself. So, it might, and people often get maybe a little closed because it's icky and it's uncomfortable, or, maybe they appreciate it, or, there's discussion points about that. But you're right. I think that, you have to kind of keep in mind when a person is activated, I mean, it's also the idea around this is that if someone's activated, it's a very different thing for something like a psychodynamic approach where someone's activated and you're giving them space and you're giving them probably too much space, and it can be quite depriving. So that's a very different, I think, in schema approach, where you're not letting them, you're activating someone, getting them in touch with the core feelings, and then you're sort of sitting back. You're really getting in there and sort of meeting that need.
Absolutely. And so I guess part of the lesson here is when you're going to give a message like that, the best place to do it is when the client is activated, when they're bringing you some vulnerability, when they're bringing you some anger, maybe when the critic's showing up, and they're in some of their stuff. And then that's when you bring that stuff, more so. Yeah. And, with anger, it might be like, hey, man, like it might simply be, talk to me about it. Like, I'm sure you have a good reason to be angry. Like, I really want to hear that, and that's validating.
So with our training, with the training that we both do, and I guess the way that we work with our supervisees, we tend to break up the liminary parenting into 4 main bits, really, don't we? We kind of, I think there's a lot of the time when we're thinking about this liminary parenting stuff, people do get hooked onto the care, nurturance, validation element, the nice stuff, which is, the first bit of, what we often would talk about. But there are other bits to that, just like a parent, I know for myself, there's a good cop stuff, which is all the nice nurturance, maybe a bit of guidance. So just to open up things to the audience, the 4 main things that we talk about really is, number 1, we want care, attunement, nurturance. We want, directly meeting the need, just like we've been talking about. The second thing, which we'll talk in a moment, is kind of more about guidance. We want, it's okay to have an opinion. If you think someone's behaving in a way that isn't consistent with improvement, you can say what you think and guide them. Sort of say, well, it's up to you. You're the master of your own universe. If you want to take that job as a drug dealer, it's up to you. It's like we might be saying, don't do that. But then that's the sort of good cop stuff. But then the bad cop stuff is things like limit setting and empathic confrontation. And, we're both parents, and, having to do that half my time, iPad off now. You've got 5 seconds to put it off, or you're not having it for the next 2 days. This sort of stuff.
And then 10 minutes later, you're like, I love you, mate. You know that.
Yeah, exactly. It's not all bad.
Have a good one.
You got to get the balance. Yeah.
But it is hard and jarring to switch roles.
Yeah, it is. It is. But, it's interesting. We've been talking a bit about how to, sort of frame this, about nurturance and validation, and like almost kind of that's one polarity. And then the other polarity is like assertion and challenging and change. Like, so I mean,
so you can almost imagine them as being a sort of on a spectrum.
Yeah.
Right. So you've got this spectrum on the left-hand side, you got care and attunement, then leading into guidance, then you're leading into empathic confrontation, then all the way on the right being limit setting. So you've got this kind of spectrum between therapist tasks that look like nurturance and validation and input, care, right? All the way through to straight up limit setting and boundaries.
Yeah.
Right.
Yeah.
And so those 4 parts of liminary parenting can lie on a spectrum. We all love a spectrum. Yeah. We all left to right. We got the,
We'll try and work up a drawing of this maybe in the show notes.
So sure. Let's do it.
Yeah.
Yeah. We'll work up one of our slides, which we put in our trainings.
Yeah. And I guess it's about being more nimble, because if we're just nurturing and validating and there for our clients, which is good. I mean, it's not being phony or anything, we are, but at the same time, it's not your job to take abuse, or we might, need to set limits, or we might need to really confront people on, not cool behavior that, isn't really getting them in, moving in the right direction too. So often, I mean, I find that, the general therapist's strength is in the care and nurturance stuff, and empathic confrontation. No one taught me how to deal with that. No one, and I guess we're working with a very unique, kind of a group of individuals that, complex problems and often really deep problems that get triggered off in relationships. So that's why that part's so full on, as opposed to if you're doing the Axis 1 kind of work, working with something a little bit more simple, you're not needing to deal with the therapy relationship stuff and to confront people and bring it up and deal with it.
And this could be a hard part about being a therapist too, because we for the most part, I always say in our trainings, almost none of us got into this to be great boundary setters. If I said to you, why did you become a therapist? No one says to set boundaries, because I couldn't wait to get to the point of setting boundaries with clients. Everyone always talks about wanting to make a difference, wanting to help people, wanting to, that sort of thing.
There's a bit of confound in that, isn't there? Yeah.
But if you look at the model, our clients, for the most part, are generally come with histories of abuse, histories of neglect, histories of invalidation. And so it makes sense that we load heavily on that left-hand side of the care, nurturance, and validation stuff. It makes sense. But at the same time as being, let's say, neglected, many of our clients also didn't have clear boundaries growing up. And so this must also be a part of the treatment. I never forget the time that I really realized this in a more of a meta way, like in supervision and thinking about other therapists. I think it would have actually been Amsterdam a couple of years ago. We had the ISST conference. Anud was talking about the trial. They did a big RCT with group schema therapy. And he made this point. He said that they had all these sites around the world. They're doing group schema therapy. And he said there was a few sites that were basically a disaster because the therapists were unable to set the boundaries. They of course they were very nurturing and they knew the model and all those things. But in the group setting, if there are one or two people that are maybe overcompensating or damaging in some way, that they really needed to set the boundaries. So there were some issues early on in the trial, in certain trial sites. But for me, I felt like it was a big collective slap to all of us as schema therapists.
It's interesting though, as well. I remember reading a paper not long ago as well that talked about the key things that made a difference for the client's perspective at schema therapy. And one of those things, we can tell you about the other two later, but one of them was empathic confrontation. Like, people saying, look, you called me out on things that I knew wasn't cool. You did it in a kind way and in an encouraging way, and I needed to hear it. And that was one strength of the model from the client's perspective too. So it's interesting we're sort of talking about that.
Absolutely. Yeah. And, the other thing about that is with empathic confrontation, often after the first workshop, folks go away and they get the idea, they just start confronting all their clients. They're like, right, I can confront everyone. Yeah. So that's a little bit of a thing to watch out for, because you have to remember the empathy part. The empathy.
Yeah, exactly.
Right.
Exactly.
So, keeping that in mind, you have to lay on that empathy really thick.
Yeah.
No one does this better, I think, maybe than Wendy Bihari, who, if you listen to her, it's such a deep, radical empathy. It's all grounded in, like, I know how hard it is for you. I know what it was like for little Johnny growing up, and no one ever listened or no one cared enough, and all that kind of stuff. You have to lay that on really thick, especially for those guys. Not so much maybe, for everybody, but...
Well, we've got that spectrum, that idea, like care, nurturance, guidance, empathic confrontation, limit setting. I guess that's an important point sort of made, that we all need different things. Some people are going to need more limit setting. Some people are going to need no limit setting. They're going to be fine. There's going to be much more of a focus. So it still goes back to that kind of, what do they need? And, what
does it need?
Yeah. Some people are going to need different things.
But thereby, the best therapist thereby is one who can flexibly move between tasks, who can recognize, I always use the example of, you might have a narcissistic client that you've been thinking, oh God, I've got to do some repair, like I've got to do some empathic confrontation. And you work up the courage and you plan it out. You go, right, this session, we're going to do it. And the client comes in for some reason, vulnerable. Something happened during the, bang, vulnerable. Okay, you got to put all that stuff aside.
Yeah, drop it. Yeah, absolutely.
Because that's not the time for it now. Even though you wanted to, you wanted it, you were prepared for it. Maybe this is not the moment. The client's already in a vulnerability.
So maybe we could chat around. Okay, so maybe just before we go into the confrontation bit, we can look at the kind of care connection stuff, because I don't know about you, but I get this a lot. And, there's issues, there's clinical dilemmas that we have in terms of boundary violations. And we do get a lot of questions in supervision and in training around, elementary parenting might, come up.
What ifs?
There's problems. The what ifs. Okay, so
I reckon, Chris, we could do a whole series, the what if series.
The what ifs
of Schemata.
Yeah,
we'll start doing what if series.
And do that in episode 21. Yeah, absolutely.
So we're going to start our what if series today, looking at limited reparenting.
Yeah. Well, okay. So one what if? I mean, is what if? My care is seen. It's become from more of a sexual way. Maybe people might have sexual feelings with me if I'm telling them that they're a good person, that you like them. Maybe this would encourage the client. Have you had this sort of stuff, or sort of feeling
never
proper?
Never. Ever.
Right. Yeah. Right. Yeah. Well, not maybe. Well, through your basket of thousands of people that you've worked with, I'm sure you've heard this before. But I mean, I've had. People ask me. I've had people come to me that have had some, sort of talked about having feelings for me. I don't think it's necessarily to do with. Well, it could be a bit about the therapy. I mean, that's okay. I mean, what are your thoughts before? Tell you mine.
I think it's a little bit inevitable sometimes. I think clients, if they haven't had their needs met, it can be confusing initially. I'll start by saying the vast majority, like 99.9% of the time, it's not even an issue.
Yeah, it's not. Yeah, absolutely.
So it's not a broad issue. I don't get this as a broad. Like, it's not like 1 in 10 clients fall in love with you or something like that. It's not. It's just not a thing. Yeah. But from time to time, I think, yes, it could
as males, maybe if we're males, we might be, working with some female, having female therapists, and they might be a little bit more wearisome of that, I'd imagine, if they're working with a male client, and I mean, I think it does, I think it, like you agree, I think it is probably an anxiety that might be overstated some way, but the thing that I'm always sort of saying is that, that's the nurturance and care might be filling a need, and it might be something that the person's really craving, and they might have some feelings for you. But don't forget the liminal parenting element of empathic confrontation and limit setting.
And boundaries, yeah.
I mean, I can remember someone who was a lovely person I worked with who was a therapist, and she had someone started to stalk her, and we just needed to stop the therapy, because that, you got to keep yourself safe. And that's an important part of the deal. It's not just about being nurturing and about available and caring. It is about being sturdy in yourself to say, that's not cool. So, I think that's what
in my experience, though, these things are not coming up as a sort of at full intensity straight away, but it builds up slowly. And so my advice would be, yes, it's inevitable that, like, for some people, this might happen. On the low percentage chance that it does, though, when it does, I think it's another opportunity for corrective experience, in the sense that,
absolutely,
yes, I'm here, I do care in a limited way, I'm the therapist, but that's all it is. And you need to be able to respect that and understand that. And if you can, then we can work together. So I think it works on a similar thing, like, your parents love you, but it's not a sexual thing, right? Or you might get care from your sister or your cousin. Those things can go together. It doesn't have to be something, right, which turns into a sexual transference.
It could be. Another thing is to kind of start to understand it a little bit in mode terms, because I remember one of my clients, she would sort of sexualize behaviors, and it's a part of her overcompensation. She'd do that as a way to feel more
attention seeker.
Well, maybe not with her. It's just, I think she felt more in control. Some sort of, it wasn't so much of attention. It was just more of, she was, had a job in working sex work. So she was much more in control on top of the dynamic, if it was like done in that way, and she could flip it into that way. So it's sort of, I wouldn't say narcissistic, but it was kind of like a way that's, I wouldn't say she was aggrandizing, but it's a way to kind of, that's her way of getting back on top of the dynamic. If it was just normal kind of,
so to speak.
Yeah. But
I think it's just something you have to deal with, right?
Yeah.
And if it comes up, it's likely to be overcompensation. Like any overcompensation, you've got to get on top of it early. Yeah.
And you know what? The other thing I always remember, doing a training with you years and years ago, and it was very true. Like, some of us that there's a high proportion of people that do schema therapy, the therapists, that have self-sacrifice or subjugation. And if you're saying to yourself, I remember this is what you were talking to me, and I was like, yeah, that's so true. Like if you've got a bit of subjugation, you're saying to yourself, just be easier if I let this go. Don't worry about it. Just be easier. That's your coping style. Yeah. And I think this is the sort of thing, if there is an issue, you do need to really bring it up, and it's not easier. You need to kind of address it and just doing it, in a empathic way. And
I always find too, the issue of flirting, like this kind of thing, often if it comes up like right from the client, it'll come in the form of some kind of flirting. Mm-hmm. And it usually starts in a low level. They might be sort of bashing the eyelids or, and so I think it's something to get on top of even at that level. Yeah. To send the message quite clearly.
Yeah.
It doesn't have to be, and the other thing, it doesn't have to be like, hey, we need to talk about this. You're batting your eyelids. Yeah. But just in terms of like what you reinforce and your demeanor, and to be clear that perhaps it would be that, you change the subject abruptly. Right. So if someone wants to talk about how they're flirting and talk about how awesome you are or something, you might say, well, let's get back to what we've been talking about, which is the model. And so just sort of diverting away from, right. And in that way, you send the message that that's a boundary. Yeah.
Another thing around the care and connection and attunement and, validation side of things, and doing it in a direct way, that the what if is around it being too much for the client, like people worrying that people might react negatively about being cared for, or might sort of, sink their boat sort of thing. I do see, I think one thing I notice, and I'm always banging on to people about this with their clients, is if you're doing something like this and someone does have a negative reaction, the classic thing with a therapist would be to make that assumption it's something to do with that about them. What they're doing is wrong. So they have this kind of implicit kind of assumption that the person's saying it's too much, it's awkward, so I must be doing it wrong. And I generally sort of say, well, I don't think it's necessarily about you. It's trying to think of it. It's just data. It's just, that's really interesting. It's interesting because I do therapy with a lot of people, and not necessarily people always have the same reaction. And it's not. Don't take it on board as.
There's two things I'm thinking. Like one is. Like the therapist who says this as their concern, like when you talk about limit reparenting for the first time and they say this, I always wonder if this is the therapist schema. Right?
Yeah, absolutely.
Like, because that's how they'd feel if someone tried to show them care. So you can see a lot of the issues in limit reparenting actually would come back to our own schemas. So that's one thing. I actually can't remember the second thing, but it'll come back to
Yeah. Well, I think normalizing, the experience and being able to, kind of find out what the part of them, maybe there's a part of the client that doesn't necessarily like, it could be a coping style, coping mode that doesn't like the intimacy, or it's too intense.
Well, so this is the second thing. So if this is what's happening, to me, it says a couple of things. One is that the level of care for the client might be outside the window.
Yeah.
So we might be laying it on too thick.
Yeah. So it's too much. It's too
much.
Too
and every client's different. Some clients lap it up. They love it.
Yeah.
Others are like, well, for some of them where really care is really too much, I think it says something about the conceptualization. So you have to sort of step back at that level and think about, what's going on in the conceptualization that makes care too much. Where does that come from?
Yep.
I don't think it means we back off. I think ultimately it means having the client accept your care is a core goal, because if they're not going to be able to accept your care, which is, I presume, a very safe form of care, you're a therapist, you can't really break, without ethics, etc. Then I don't think they'd ever be able to receive care and have stronger forms of intimacy. So I wouldn't back off, but maybe we're talking about the window. It might also reflect an avoidant attachment style for the client.
Yeah, I mean, when you're sort of talking about the window ways, the practical ways that we could do that, we could be, instead of talking directly to the person, going, Rob, I just really think you're a lovely person. I really care about you, mate. And I know it's hard this weekend. You might be like, oh, can't handle this. I might be instead going to talking to an empty chair. And I say, look, I think this is like Mini Rob. Mini Rob is here, and I'm talking to Mini Rob, and you're next to me. And I'm talking to the empty chair, and that could be a way to reparent, or I might get a figurine or something. Yeah. And you might be looking at, the figurine or the empty chair alongside me and going, yeah, okay. And it's less intense. The other thing I found that was quite cool from, working with some of the guys that are involved with sort of trauma is that even just, things like the imagery. Part of imagery, we're doing reparenting, but it's in an imagery context. But just starting really simple. I mean, you're still doing reparenting in the imagery, but you could be doing things just really mundane. It could just be backing right up and just get an image of us doing the washing up together. That might be enough to get that reparenting, the blend between limited reparenting and experiential techniques. But it's starting at a really low baseline and building that up over time.
And saying things, very intimate, like things like, I'm proud of you and stuff like that. I mean, you just back off maybe on that a little bit for some clients. Yep. So all of the techniques have to be sort of within a window, a therapeutic window. And showing care and nurturance is one of them.
Yeah. So we've got the care and nurturance stuff on one side. What about flipping over to the empathic confrontation, limit setting stuff? So can you think of any sort of what ifs in regards to that? Like, I've got a couple, but if what if the biggest one for me is, what if the therapy relationship is ruptured if I bring this up with them and they don't sort of, they don't like what I'm hearing.
What if they leave?
Yeah. What if they leave, or what if,
like, just to make an example, client wants to come and put shit on you the whole time. I don't know, aggrandize or something, or, it could be anything. It could be just come and download.
One more time.
Client might want to come and download, just constantly download and control the therapy and not actually do any therapy. So what's your choice? You either address it or you're going to sit there and just kind of be passive and cop that, for eternity.
So I guess I sort of see the limited parenting, the escalation between empathic confrontation. I think we still have to start probably empathically confront, and then if things get really difficult, like people are stalking people or people are abusing people, kicking off, then that's where the limit setting comes in. To be honest with you, I don't do a lot of limit setting because I don't need to, because people generally aren't pretty respectful. But the other thing I thought as well is that you can't say, if you've got someone showing up and they're being difficult in session, or they're being kind of untoward, is it is tricky to do things like empathic confrontation when you don't have a formulation and you haven't seen them very, very much. I mean, I don't think you can do it, after 2 or 3 sessions. No. Well, you need a little bit of glue. You need to sort of take it a bit, and protect yourself.
You need a good therapy relationship. That, in some ways, right, the empathic confrontation part is, that you need enough empathy. You need to understand them, their childhood. They need to know that you get it, right? So all those tasks are very important early on, like the first 5, 6 sessions, even 10 sessions for some clients. You got to get through that stuff first.
Yeah. And I think if you've got the formulation, you could kind of get away. I think if you've got someone who's presenting with narcissistic or overcompensating type behaviors, if you pitch it to them and they kind of get it, then you can get away with a lot more empathic confrontation, as opposed to just coming out of nowhere and then sort of starting to bring up, difficulties or the way that they're acting and not.
And sometimes the formulation,
exactly,
is a way of saying, oh, right, like I get it. This kind of, the top dog, like, he's really helped you, and, you whatever, you've done so great in your job and you sort of dominate, and that sort of helped you in different ways. But what about the other side of it? Have you noticed? But even just doing it on the model on the wall, have you noticed this side in relationships, or have you noticed this side? Like when you came here, you said that your wife's leaving you. Like, what's this side got to do with that? So some of that can be explored in ways that's not such a confrontation.
And with empathic confrontation, we could do a whole session on this, and we're hopefully going to be having some more training on schema therapy training online the next couple of months. But the empathic confrontation is triggering for the therapist. It can be, for I would say 80% of people having difficult conversations isn't something that
this is actually the real thing. I think therapists know what to say. Like if they wrote it down or something, they know what to do. It's more how it makes us feel. It's
the feelings that get in the way. Although, what I always found when I was learning how to sort of get better at empathic confrontation is to have some scaffolding and things, have some sort of lines, it's hard for me to be there for you when you do this, or, I get it. I get why you do it. But other people don't get why you do it, and other people won't have the time for you when you do that. So you need to do something about it.
Man, I'm a therapist. Given the I'm a therapist thing, I get it. I'm trained to do this, right? I can get it, but I'm worried about other folks.
Yeah, and they won't get it, and they'll sort of walk away, and they won't have time. So, if you're interested in that, we might try and do even another podcast looking at that. I do, like you've mentioned, Wendy Bahari of America, fantastic presenter and trainer, and hopefully will be a part of doing some training this year, is excellent. And it's good to listen to she's got lots of stuff on YouTube. You can listen to some of that stuff as well. Just the way she speaks and the way that she can kind of verbalize this is really helpful. That's also, and you know what, just why there, she's got a great book. If you're interested, Disarming the Narcissist, a big plug for that. There's a new edition that's come out, and it's great for therapists, but also for our clients. So have a look at that too. We'll put that in the show.
What do you think about this, Chris? What do you think about whether it's in imagery or your empathic confrontation? Something I reckon that's cool is getting exposure to different trainers and the one-liners. That you pick up off a different trainer when they're in an imagery or they're doing, empathic confrontation. It's like, bang, there's this one-liner, right? That's something over the years I've thought about, that I've been impacted by different trainers. Can you speak to that? Has that been the case for you too?
When I've done a couple of videos with a couple of Dutch presenters, and we've all talked about how we all start talking like the others. We all kind of have this amalgam, and even listening to some Jeff videos, watching Jeff, watching him do his work, and then myself and some other trainers, we all sort of start doing it. And then one other trainer starts using something I've used, and I start using what they do. We all kind of get this amalgam.
I've been really impacted by your stuff, and also I think the videos you've been doing, and also Remco, he's another one. He just got some great one-liners. Yeah, right.
And it's good because you can model it and see it. It's something in the moment that you don't necessarily think about, but that's, I do think that if you've got troubles with limited reparenting, particularly in empathic confrontation, it's definitely worth to watch videos, get feedback, practice it. It's like a state-based experience. Like I think if you're practicing it, if you can get state-based memory where it's like, oh, I've got to bring this up, and you've done this before, you'll know what to do because you've practiced it and you've watched it, as opposed to reading it from a book. It's not necessarily going to be what you need. Hey, just before we were going through the time, so we're doing quite well, but I was just also thinking another issue around limited parenting is, we've talked about the kind of closeness and people taking it the wrong way, but, we often get feedback from people, particularly learning about the model, about dependency. And, we want to be a real therapist, and we want to have appropriate self-disclosure with a client, so there's really two things really. There's the self-disclosure kind of element. That's something that comes to mind as well. Or what if I disclose and it's they take it the wrong way? But also, if we're having this caring, validating, self-disclosing, authentic therapist type of presentation, whether that fosters, a dependent client. What are your thoughts?
If you're going to be authentic and a real person, more of that, bringing more of that into therapy, there's always the chance that someone could take it the wrong way, but it's probably not you. The client is coming and they may be sensitive about certain things, and your realness could touch on certain things. I think that's normal, and it's something to deal with in a therapy. But it's not a reason not to be real. For the most part, I think clients really benefit from that when they see that you're being more of yourself and just being authentic. 99 times out of 100, that is seen in a positive way. Yeah. So,
and it can be tricky though, because I guess we get trained boundaries, and then suddenly we've got, us as trainers telling people like, it's okay to be self-disclosing, and suddenly for some people it frees them up and go, okay, I'm not worried about some licensing organization or authority tapping me on the shoulder and investigating me. They can just relax a little bit.
And they come and they say, you told this guy what book you read on the weekend.
Yeah. I mean, it's, crazy. But, I remember there's the now president of the International Society of Schema Therapy, Jeff Conway. He mentioned it in training a long time ago. And I thought that was a really good analogy of like, if you're going to self-disclose, think of it as it does the self-disclosure aid the connection you've got with the client. And the attachment. And, a good analogy would be like, maybe I've got, relationship issues and my client's got relationship issues and they're talking about divorcing and I've just been divorced and I'm just going through a messy divorce and they're going, I'm really tough going. I'm going to see the lawyer. And you're like, yeah, I know what it's like. I've been to my lawyer this morning too. Yeah. The whole thing sucks.
So there is a limit, right? There's a limit where it's not therapeutic or where it might be therapeutic for you.
And them, it's not helping them feel kind of safe in the relationship. Suddenly it's more complicated. But if I said, 30 years ago or 10 years ago, I went through a really messy divorce and it was horrible and I know what it's like and I can, I know what it's like to go and see lawyers and I know it's like to not see your kids. I get it. It's tough. That would be completely a different thing. I think that would be possible.
Yeah, I think that there's some boundary there, isn't there, where it's you don't want them starting to worry more about you than maybe you're worried about them or.
So you're going to have to think about, is this sort of past history or current history type of thing? But the last thing was the dependence thing. And, we were talking about this before the session around some of the DID training and some of the recent DID case study looking at limits, limits in terms of therapy. I don't know if you want to speak to that.
So I guess this comes back to the question people, therapists often ask in the training, and it's linked to the idea of dependency, and that is how long should schema therapy go for?
Yeah.
All right. So I don't know. Do you have an answer for that? I mean, it's a common question. How long should schema therapy go for?
Well, I mean, part of me thinks it's a part of it is massively to do with the coping mode. If someone's got very strong coping, it just blows things out. You have to spend a longer amount of time.
Could spend a year or so just trying to get past that.
At least, yeah. And I think that, RCTs, it's different because the person comes. It's different if you're working in private practice or you're in a different setting where someone's turning up and you're getting someone, wanting your help. Yeah, it's a bit, you have to probably be a little bit more flexible. But, speaking to Marlene Reichenberger in the Netherlands, she's quite resolute in terms of, treatment.
So this is what, and my personal thing on this now is, for the most part, based on the research trials with borderline clients and now with the DID clients, my own view is that an upper bound limit of 3 years is probably ideal.
Yeah.
That you start out with the client, and if they want to know about how long therapy goes for, if they have a personality disorder or problems to do with complex trauma or dissociation, so in other words, they're a chronic client. You might give them the idea that therapy might last anywhere from 1 to 3 years. And of course they could finish whenever they'd like. And if things, responded really fast, the therapy could go fast. But, that give them the idea that there is an upper bound limit, that after 3 years, the therapy would conclude, And that part of the idea of that is, you need to give them enough time to change and to work on it and not be sort of feeling like, oh no, the therapy is going to end anyway. And like it's right. So have enough time to get some work done. But also, I guess it's that without having an end date, it can sort of feed into dependency issues that the client would like your intervention. They would like your limited reparenting. But not be motivated to take on board this sort of autonomy phase. The behavioral stuff, taking the autonomy phase, taking more responsibility for the change. So, we think it is important, usually in that last year or in the final phase, whenever it might be, that you're experiential techniques, for example, are more heavily loaded towards the healthy adult doing a lot of the work. That you're expecting a bit more in terms of the behavior change stuff. Now, if the client thinks you might be there forever, that can sort of take a lot of the motivation out of it.
Absolutely, yeah. So something that I've noticed probably in my work in the last couple of years is that I definitely bring up the point of I'm trying to get them to look after themselves a lot more. From the point, even at the start, I might do imagery, or even on the side going, the point of me doing the imagery now is to teach you to do it. And I want you to do it one day. I want you just to have that as
so you set that expectation.
Yeah, exactly. Rather than you being a passive thing that's just like, oh, you're going to do therapy to me, and then I'm going to turn out in 18 months or whatever, and I'm going to be fixed. It's more them engaged and sort of.
This is an issue, like when to terminate a client like this, particularly those with chronic problems and say with personality disorders. I don't know if you've read this, Chris, but I'll send it to you and we can put it in the show notes. There's a famous paper in psychoanalytic therapy by Freud. It's called along the lines of analysis terminable and interminable.
Yeah, right.
Right? So basically meaning that, that you should terminate, or in some cases that you can't terminate.
Yeah, right.
Right, that the client needs so much help. So, but it really speaks to this, and it's kind of cool actually to read something like an old paper that's 80 years old or something.
Yeah.
On this issue. In other words, he was struggling with this exact issue.
Yeah. Exactly.
With these chronic clients, some of them it's like you should never terminate, and for others it's like you absolutely have to. You have to set an end date. And he speaks very much about this exact issue. And it's very interesting.
So a dilemma. Yeah.
So he came up with basically the idea that once you decide to set an end date, to stick to it. You have to stick to it. He sort of this is based on his ideas. That you set an end date, otherwise the client would become dependent, or sort of only want to come to the therapy to get nurturance.
I guess there's a runway, isn't it? You're kind of needing a runway for that to happen, as opposed to sort of like, okay, well, we've got 3 sessions and that's going to be it.
100%.
Needing to know this six months before.
100%. So you're wanting to make that, especially with these clients, a really clear runway. I would even like as much as a year with a borderline client. I want it to be something that they see as like the final step of autonomy and learning to have more responsibility to take care of the child. The other thing he says in that paper, which is kind of interesting, is once you set an end date, that you have to stick to it. And he says something like, if you don't stick to it, the client, the patient would lose all trust in you or something. In other words, I wouldn't respect you. That you said. That's interesting. We'll put that in the show notes.
Definitely put that in the show notes. Yeah, absolutely. Excellent. Okay, well, we have completed episode 21 of the What's the Schemata podcast. And we hope you enjoyed the presentation and have a chat. I thought it was like a fireside chat I've had in my mind. I should have got the little
you and I beside a fire.
Yeah. With a cigar, or maybe some cognac or brandy or something. I don't drink.
I wish. But the idea for this one came from a sort of a what if idea and some what if ideas around limited reparenting. But if anyone has some other topics around, or even what if questions, Chris and I are starting to collate some, and that we might sort of drive some of our future podcasts. Some of those what if questions are really cool. So if you have anything like that, if you could reach out to us at info@schematherapytraining.com. And you might sort of see in the future that we're running another one on your topic.
Yes.
Or it's a way to give us some feedback anyway. Yeah. So.
And if you're interested in further online training, we've got a number of courses that are available on Schema Therapy Training Online. We've also got live training in Australia, in Singapore, and possibly New Zealand next year. Yeah. And to everyone around the world that listens to us, I hope you're having you're well in the different pockets of the planet. And we often see comments from people around the place enjoying the podcast. So we've got to 21. We're hoping not to stop and continue once a month or so.
I wonder if we can make it to 121. We're going to be sitting there.
We'll be there. Absolutely. You get some of these YouTube podcasters are pumping it 2 or 3 out a day.
Oh, mate. Yeah, we're not that good. We're not that good. Prolific, but We'll be sitting here, in our 60s. Yeah, what's a schemata?
What's a schemata? Okay, everybody. So thanks, Rob. And everybody, I hope you enjoyed today. And
we'll see you around.
See you later.
See you around. Bye.
Bye.